All right, so we are going to cover musculoskeletal system tonight. And then what? All right, so musculoskeletal system. Number one, we have patient fell and fractured his left femoral shaft in three places. The fracture is treated with an ORIF of the left femur with an intramedullary nail and then interlocking screws, and those were placed peritrochanterically. The orthopedist also places the leg in a plaster splint prior to leaving the OR. So, what codes are we going to report? And I don't know what these are. So with this, sorry, with this one, um, we first need to look at ORIF. Do we know what ORIF, that abbreviation or that acronym
Open
stands
reduction,
for?
internal fixation.
Yep. It's an open reduction with internal fixation. Okay. So let's go take a look and do this one from process of elimination. So we've got two that have 29505. Let's go look at 29505. So 29505 is an application of a long leg splint, which is thigh to ankle or toes. So while we did place the leg in a plaster splint, okay, we need to understand or we need to remember that if we do a treatment, then that initial casting or strapping is included. Okay. So if you don't remember that, look at your guidelines. Your guidelines at the very beginning of the application of cast and strapping. If you have the 2024 manual, it's on page 200. So on that very first sentence, says all services that appear in the musculoskeletal section include the application and removal of the first cast, splint, or traction. So knowing that, we should not code 29505, right? Because the cast application is going to be included in that CPT code that we use for the ORIF of the left femur. Does that part make sense? Mhm. Okay,
Thank you. Yes, it makes sense. And I'm
perfect.
happy I know where that guideline is now.
Yes. Yeah, I know. That's always one that can be a little tricky. So just remember that if you can't remember what's included, it's at the beginning of the cast and strapping, not the actual procedure itself. Okay, so let's look at 27245. So your code description for 27245 is the treatment of an intertrochanteric, peritrochanteric, or subtrochanteric femoral fracture with your intramedullary implant with or without interlocking screws and a cerclage. Is that what we did? Is that the right location? What do you guys think? 27245. If we're doubting it, let's go ahead and go to 27506. 27506 is the open treatment of your femoral shaft fracture with or without external fixation, with insertion of intramedullary implant, with or without cerclage and or locking screws. So, who thinks it should be 27245? And then who thinks it should be 27506? Okay, Dawn says 27506. Okay, Tansy says 27506. Is there,
Well,
okay.
I would
No,
say
go ahead.
27506 because everyone is saying that.
So 27245, and this is where you have to be really, really careful with your wording, okay? Because these look very, very similar, right? 27245, the anatomic location of the 27245 is of the intertrochanteric, peritrochanteric, or subtrochanteric of the femur. Here, the fracture is in the femoral shaft, right? So that's why our 27506 is the correct code. And because the code description for that is open treatment of a femoral shaft fracture. So they're throwing in this word peritrochanterically to see if you are going to pick up that word in the 27245, where again, that 27245 is the anatomic location of the peritrochanteric area, not where the interlocking screws were placed. Okay, does that make sense? Any questions on that one?
No.
Okay. Number two, patient is given xylocaine, which is the local anesthetic, by injection in the thigh above the site to be biopsied. A small bore needle is then introduced into the muscle about 3 inches deep, and that muscle biopsy is taken. What CPT code is going to be reported for that service? So we have two that are very close to each other, right? We have 20205 and 20206. Those are both for muscle biopsies. We just need to figure out which one we're going to use.
And I do have a question on this, and I don't want to take up too much time.
Mhm.
For the 20205, it's saying deep, and then the 20206 is percutaneous. Oh, wait,
Mhm.
no. Yeah,
Yep, it's
percutaneous.
percutaneous needle.
And I know we only went in 3 inches, so I'm a little
Okay.
confused about
Yep.
that.
Yep. So the key is your 20200 and 20205. Those are incisional biopsies. So those where they actually have to take a scalpel, make an incision, and go in and cut it out. Whereas your 20206 is with a needle. So that's where you have to pay attention. Even though they're telling us that they went 3 inches deep, truly they used a bore needle. So this is going to be your percutaneous needle.
Nice. Thanks for
And not
explaining that.
incisional. So what I always recommend is next to the 20200 and 205, write the word incisional. So that way it's a visual reminder that this is not used for a needle biopsy, even if they do tell us that they go 3 inches, quote unquote, deep, right?
Okay, so you recommend to write incisional near two.
Yep, incisional.
Okay.
Yep. And that little bubble for 20200 and 05. Okay. So does that make sense to everybody? Even though they're telling us they went 3 inches deep, since they used a bore needle to do the biopsy, then that's going to be your percutaneous needle biopsy and not the incisional muscle biopsy that is the 20205. Any questions on that one? Okay. Number three, we have a 63-year-old man that presents with a neck mass to be excised. The neck mass was palpated and an incision was made and carried down through the dermis with electrocautery. The subcutaneous tissue of the skin was opened, encountering an organized mass with a benign appearance of lipoma. Using careful blunt and sharp dissection, the mass measuring 5 centimeters was completely excised and around its entire circumference, leaving the capsule intact. The mass was then removed from its posterior attachments using electrocautery. So when you're in your testing element, okay, it's going to have up in the top left-hand corner what system you're in, right? It's going to have it's the 20,000 series. So what I always recommend is go look at your 20,000 series codes first. And then if you need to decide whether you need an integumentary system, right? However, with this one, they are indicating that the mass is in the neck, right? So if it's within the tissue of the neck and not on the surface of the neck, on the like the epidermis or the dermis, then we're still going to be in our musculoskeletal system. So always kind of those are going to be your two indicators, right? Is going to be again where the what group we're in. So here we're in the 20,000 series for musculoskeletal, and then also where it is. Okay. So again, it's a neck mass and not a mass on the neck. So we have 21552 and 21555. So your 21552, they're going to both be underneath the same parent code. An excision of a tumor, soft tissue of the neck or anterior thorax. Subcutaneous, one is less than 3 centimeters, one is 3 centimeters or greater. So are we going to use the 555 or the 552? Yep, we're going to use 552. Okay. Any questions on that one? Okay. Let's do number 4. The number 4
No,
is a 42-year-old
no,
with
I'm waiting till Friday. Should I?
we have a 42-year-old chronic with a chronic right trochanteric bursitis, and they're scheduled to receive an injection at the pain clinic. And there's a 22 gauge spinal needle that's introduced into the trochanteric bursa, and a total volume of 8 cc's of normal saline, and then 40 milligrams of Kenalog, also known as triamcinolone acetonide, and that's injected. So for this one, okay, we have J3301s in all 4. However, one is with 4 units, and then or two of them are with 4 units, and two of them are with 1. So let's go take a look at J3301. So we're going to go to our HCPCS code first for this one. How many milligrams is 1 unit of J3301? Yep. So each code is for 10 milligrams. And we had 40 milligrams of that Kenalog. So we're going to use 4 units. So it's either going to be A or C. And then we need to go to our CPT, because we know it's either going to be 20610 or 20550. So let's go to the 20550. So 20550 is in an injection for a single tendon sheath or ligament aponeurosis. And so here we are doing the injection into the trochanteric bursa. So we're not injecting a tendon sheath. So let's go to the 20610. And your 20610 is for arthrocentesis, aspiration, or injection of a major joint or bursa. And it gives you the examples of a shoulder, hip, knee, or subacromial bursa. And then it's without ultrasound guidance. So we're going to use our 20610. And then we need the RT modifier because it's done on the right side. So any questions on that one?
Tiffany, can you please
Yeah.
explain? You highlighted the bursa in blue. I can't say it, the word before that starts with tro.
The
Where
trochanteric
it,
bursa.
yes. And
Yeah,
then
so
where is,
your trochanteric area is going to be in your hip.
oh, okay, so that's where anatomy needs to come in
Yep,
then.
that's where your anatomy, yep, your knowledge of the anatomy in your joints.
Okay, thank you.
Yep, you're welcome. Any other questions you guys can think of on this one? Okay. All right. Number 5, we have a patient presented with a closed displaced supracondylar fracture of the left elbow. After conscious sedation, the left upper extremity was draped and closed reduction was performed, achieving anatomical reduction of the fracture. The elbow is then prepped, and with the use of fluoroscopic guidance, 2 K wires were directed, crossing the fracture site and piercing the medial cortex of the left distal humerus. Stable reduction was obtained with full flexion and extension. K wires were bent and cut at a 90-degree angle. Telfa padding and splint were applied. So what CPT codes are we going to report? Okay. So for this one, we have 2 that have 29105. So let's go take a look at that code and see what that is. So the 29105 is going to be the application of that stent, or the splint. On this one, it's a splint, not a stent. So are we going to report the splinting application? No, no, we are not going to report that. So we know that D and A are out of the question. So now we need to go look at 25438 or 24538. So 24538 is a percutaneous skeletal fixation of supracondylar or transcondylar humeral fracture with or without intercondylar extension. And then 24582 is for percutaneous skeletal fixation of your humeral condylar fracture, medial or lateral, with manipulation. Who was that just had their hand up? I heard it pop up, but I didn't see the name.
It was me. I'm
Okay.
sorry.
No, you're fine. You're fine. Did you have a question?
No, ma'am.
Okay, I didn't know if you hit it on accident because with it popping away pretty quickly, I just wanted to make sure you didn't. Okay.
I meant to put B as the answer. I put A instead. My bad.
Okay. So you think it should be 24582. Okay. Does everybody agree it should
Yes.
be 24582? Or what else what does everyone else think? Okay. Don thinks it should be the 38. Okay. So what's making you think, and Lovely, if you want to say, what's making you think it should be the 24582?
That's my bad. I know that's the shoulder.
You're fine. You're fine.
I know we're talking about the elbow. I had to go back and look at it. I'm sorry. I was jumping
Yep.
ahead too fast.
You're good. You're good. I know it's easy. So 24538 includes the supracondylar or transcondylar humeral fracture, right? So we have the displaced supracondylar. And then I feel like there was another thing in here. Yep, we had on the left distal humerus. Whereas 24582 is only a humeral condylar, not supracondylar. Okay. So it should be the 24538. So Don, you were right. You were right. Stop second guessing yourself.
I think I got confused.
Yeah, yeah. So the 38 includes the supracondylar, which is what we've got here, whereas the 24582 is just humeral condylar. Okay. So don't skip over those little things here. Those little words. Okay. Any questions on that one?
Tiffany, I'm sorry. I have
Yeah.
one
No, you're
question
fine.
on number 4.
Okay.
That word that you highlighted in blue, the
Mm-hmm.
I can't pronounce it,
The
whatever.
trochanteric.
Yeah.
Mm-hmm.
Is that not in the shoulder versus, I thought you said knee, but I'm confused.
The trochanteric bursa,
Is that the shoulder area?
I think it's the hip, but let me double check because I think I said hip earlier
Mm-hmm.
and my brain is now, I'm second guessing myself. Let me
I
look.
had a note in my book that it was in the shoulder area. So I just want to make sure I didn't
The
incorrectly write that.
trochanteric bursa is in the femur, so it's going to be in the hip.
Oh, it's in the hip. Okay, so I
Yep,
need to
it is
correct
in
that.
the hip. Mm-hmm.
Okay. All right. Thank you for that
You're welcome.
clarification.
Nope,
Thank you.
absolutely. You're very welcome. Okay. Any other questions on either of those? Okay. Let's look at number 6. We have a 45-year-old male that presents to the operating room with a painful mass of the right upper arm. Upon deep dissection, a large mass in the soft tissue of the patient's shoulder was noted, and the mass appeared to be benign in nature. With deep blunt dissection and electrocautery, the mass was removed and then sent to pathology. Okay, so for this one, again, we don't have 2 that are the exact same, but we have 2 that are pretty close, right? We have 23076 and 23075. So your 23075 is going to be an excision for a tumor, soft tissue of the shoulder area, subcutaneous, less than 3 centimeters. And then 23076 is an excision, tumor, soft tissue of the shoulder area, subfascial. And then it's less than 5 centimeters. So for this, we know we are removing a mass, right, which is also known as a tumor. So your mass was removed. We are in the shoulder area, right? So that part is correct. Now, do we know if it was in the subcutaneous or the subfascial area?
Hey, I'm sorry, Tiffany. My system went out, I think. Like, what are we doing? I'm sorry.
No, you're fine. We're on number 6.
Okay, thank you.
Okay. So it says deep blunt dissection, but does that tell us how deep they went? Are they telling
No,
us if they're still in the subcutaneous area or if they've gone subfascial into the muscle?
no.
Right.
So since
So,
they didn't tell us, we have to do subcutaneous.
yep. If they do not tell us the level in which they went, then we have to go to the lowest. Because if we think about it, do we have enough documentation to say that we went to a deeper level? If we don't, then we just have to code it to the least invasive. In the real world, you would end up going back to your provider and asking them. But from a testing perspective, if they do not tell us how deep it is, how large it is, how whatever, right? Now, if they told us that they went to the subfascial area, but they didn't tell us our measurement, we would have to go to the 23076, right? But in this instance, since they're not telling us subfascial or subcutaneous or the depth of which they went, we have to always assume it's the lowest. Does that make sense?
Yeah, that actually makes a lot of sense.
Good.
And the lowest would be the subcutaneous.
Yep. Yep. Because your subcutaneous is just that tissue right underneath the epidermis, whereas your subfascial is going to go down underneath that. It's going to go underneath the fascia and into the nerves and the muscles and things along those lines.
And sorry, I just had a quick comment.
Mhm.
So this is kind of like a general coding rule. If we don't have enough information in the scenario, we typically code the lowest.
Yep. Yep.
Okay.
Always go to the lowest if you don't have documentation for a higher level.
Okay.
Yep. Okay. Go to number 7. The patient has a torn medial meniscus, and an arthroscope was placed through the anterolateral portion for the diagnostic procedure. The patellofemoral joint showed grade 2 chondromalacia on the patellar side of the joint only, and this was debrided with a 4.0 millimeter shaver. The medial compartment was also entered, and a complex posterior horn tear of the medial meniscus was noted. It was probed to define its borders, and then a meniscectomy was carried out to a stable rim. So we have 2 different codes that are the same. We have 2 with 29881, and then we have 2 with 29877. When that's the case and you have 2 that are second listed, right? I always like to go to the first one, whichever one it is that's listed first in my 2 options, because the 29877 sometimes can be included, right? So if you see the 29881 is in 2, one of them has the 29887 or the 29877. Then we have to determine, is that 29877 needed in addition to, right? So let's go to the 29881. So your 29881 is an arthroscopy, knee surgical with meniscectomy, either medial or lateral, including any meniscal shaving, including debridement, shaving of articular cartilage, same or separate compartments when performed. So we know we need the 29881, right? Because that's going to be for the meniscectomy. It includes any debridement or shaving. So would we need to code the 29877? We do not need the 29877 because our shaving and debridement is going to be included in that 29881. Okay. Any questions on that? So number 8, a 50-year-old male had surgery on his upper leg one day ago to remove an intramuscular tumor and presents with heavy serous drainage from the wound. He was taken back to the operating room for evaluation of a possible bacterial infection. His wound was explored down to the rectus femoris muscle, and there was a hematoma discovered, which was very carefully evacuated. The wound was irrigated with antibacterial solution, and the wound was closed in multiple layers. Okay. So for this one, do you want to rule out with ICD-10 or do you want to do CPT? Because you could rule out with ICD-10. No, you can't. Just kidding. I thought that was the 810 on both of them. So either way, we're going to have to look something up, right? Because there's not a, no, there is. The 10140 is in A and C. So look at the 10140. See what that is. Even though we're in the musculoskeletal section, there's 2 of them there. So let's go look at 10140. 10140 is an incision and drainage of hematoma and then seroma or fluid collection. But again, okay, remember, we are in an intramuscular setting, right? So that 10140 is not going to be our code, right? Because we're intramuscular, which is going to make it in the musculoskeletal system, not within the integument. Okay. So now let's go look at 27603. Two seven six zero three is an incision and drainage, leg or ankle, and it's of a deep abscess or hematoma. And then 27301 is an incision and drainage of a deep abscess, bursa, or hematoma of the thigh or knee region. So did we do an incision and drainage, leg or ankle of a deep abscess or hematoma, or did we do incision and drainage, deep abscess, bursa, or hematoma of the thigh or knee region? The 27603. Yep. So we did it in the upper leg. So the upper leg is considered the thigh region, right? 27603 is leg or ankle. And then 27301 is thigh or knee. So which one is more specific, generic leg or thigh? It says upper leg. Which one is more specific to our scenario? The generic leg or ankle or 27301, which is the thigh or knee? Right. It's going to be our thigh. Sorry, I think my messages are delayed for some reason tonight. So yes, it's going to be our thigh. So our answer is going to be the 27301. Okay. So just be careful that you're not stopping at just the fact that we did an incision and drainage on the leg. Okay. So we always want to make sure that we're in the right anatomic location as well.
I'm assuming that we use modifier 78 because he originally had surgery and then went back in because of bacterial infection.
Yep. Yep. And it's an unplanned return to the operating room. Yep. Having to go back in. Yep. The fact that it was just a day ago and we're still within that post-op period of that procedure. Yep.
Okay, thank you.
You're welcome. Good question.
And Tiffany, just to clarify, you said the upper leg, being as the upper leg, that will be considered the thigh. That's how we can recognize
Yep.
that as, correct?
Mm-hmm. Well, yep. Whereas just your lower leg is going to be your shin and your calf area.
Okay.
Yep. Upper
Got
leg
you.
is going to be your thigh. Yep.
So if it was like a lower leg, it'll be more that area, the shin or the ankle area.
Yep.
Okay. Thank you.
You're very welcome. Another way to look at it is if you look at the 27603,
Mm-hmm.
that red heading that's directly above it, what does that red heading state?
Oh, it says leg, tibia, and fibula,
Yep.
and ankle joint. Okay, gotcha.
So we know that
Okay.
our tibia and our fibula are the lower portion of it. Yeah.
Okay, gotcha.
Yep.
That's perfect.
Okay.
Yes. Thank you.
All right. You're welcome. Absolutely. Any other questions? Okay. Let's do number 9. 47-year-old patient was previously treated with an in or an external fixation for type 3A left lateral condyle tibial fracture. There is now non-union of the left proximal tibia, and he's being admitted for an open reduction of that tibia with bone grafting. Approximately 30 grams of cancellous bone was harvested from the iliac crest. The fracture site was exposed and the area of non-union was osteotomized, cleaned and then repositioned. Intrafragmentary compression was applied with 3 screws and the harvested bone was packed into the fracture site. So we have we can do a couple. We have 2 that have 27722, 2 that have 27724. My numbers are like mixing up on me tonight. And then we see S82.122 and S82.102. So which one do you guys want to do? We haven't really done anything with ICD-10. So let's do ICD-10. I'm making the decision for you. So let's go to our ICD-10 book. Go to S82.122 and S82.102. So S82.122 is a displaced fracture of the lateral condyle of the left tibia. And then 102 is an unspecified fracture of upper end of the left tibia. So should we use 122 or 102? The 122.
Sorry, I didn't get to the code, but I was going to say the
You're
one
fine.
that says the left.
Yeah. Well, I think they're both for left. It's just a matter if it's unspecified fracture or if it's a displaced fracture.
Oh, okay.
Yep. So we have our type here, the type 3A. And that's going to give us, we know that that's going to be a displaced fracture. So, yeah, I'll get that. So now we need to go look at our 7th characters and decide, should it be N or should it be S? So based on the information that we have, is this going to be a subsequent encounter or is it going to be a sequela? Yeah, it's going to be a subsequent encounter. It's not a sequela because it's not, the acute phase of that fracture is not completed. Okay. So the treatment, they are still in the healing phase. So if they're in the healing phase still and they're just now finding the non-union, then we're going to be your subsequent encounter. So it's actually going to be the letter N.
Where do you find N?
It is on, do you have the 2024 AAPC?
No, I have 2023.
Okay, no, you're fine. It's going to be at the very beginning of your S82 category. I'm trying to pull out my 2023 ICD-10, but it is buried. I can grab you a page number real quick. S82 is going to be on page 1117.
Thank you.
You're welcome. So remember, a sequela is going to be something that happens down the road. Whereas a subsequent encounter, they're still in their healing phase. So a sequela, you're going to have to be over the acute healing phase. You're going to have to be out of that. And then you come back 6 months after you've been basically cleared by your orthopedist at this point. It's not going to be something that's going to show up during the healing phase. It's going to be something that shows up after everything has been done. Does that make sense? Any questions on that one?
I have a quick one. So if it's subsequent, that would also be included in the global package, right?
Yes.
Okay,
Yep.
thank you.
Let's do number 10. An elderly female presented with increasing pain in her left dorsal foot. The patient was brought to the operating room and placed under general anesthesia. The curvy linear incision was centered over the lesion itself. Soft tissue dissection was carried through the ganglion, and the ganglion was clearly identified as a gelatinous material. It was excised directly off the bone and sent to pathology, and there was noted to be a large bony spur at the level of the head of the first metatarsal. Using a double action rongure, the spur itself was removed and sequestectomy was performed. A rasp was utilized to smooth the bone surface, and the evernated bony surface was then covered utilizing bone wax. The wound was irrigated and closed in layers. So what CPT codes are we going to report? So let's do two. We have two that have 28090 and two that have 28092. So let's go look at those and see which one we should use. So 28090 is an excision of lesion, tendon sheath, or capsule, and that's in the foot. 92 is your toes. So are we in the toes or are we in the foot region?
We're in the foot.
Yep, we're in the foot. So we are going to rule out the 92s. So now we need to decide, do we need 28045 or do we need 28122? So 28045 is an excision, tumor, soft tissue of foot or toe, subfascial less than 1.5 centimeters. 28122 going to be a partial excision of a bone. And that's tarsal or metatarsal bone except for talus or calcaneus. So did we remove a portion of the bone or did we remove a tumor?
Portion of the bone.
Yep. We did a portion of the bone. Yep. So it's going to be the 28122. Any questions that you guys can think of on this one or musculoskeletal?
Sorry, I just wanted to I don't know if you got, because my system keeps cutting out. I don't know if Carmen got her question answered, but I was going to tell her that in front of every chapter, they have like anatomical illustrations and it kind of goes over that specific system, like in all of the like the illustrations. Before every chapter, it shows like the different systems. I don't know how to explain it, but do you know what I'm saying, Tiffany?
Are you talking in that AAPC textbook?
Yeah.
Yeah. Carmen, remind me, do you have the AAPC textbook or are you looking for something in addition to that? If you want to shoot me, and I don't know if you're still on or if you had to walk away for a minute. If for anybody else, and I'll send her a message, but anybody else that's curious about a good textbook, or a good book to study the parts of the body, there is a book on Amazon. It's by Betsy Shyland, Shilend, and it is Medical Terminology and Anatomy for Coders. I believe it has a red front. I'm trying to look it up real quick and show you guys what it looks like. But it is, oh, maybe it's not a red front. I don't know what I'm thinking of that was a red front then. Oh no, it is. It is. The fourth edition is the red front. So let me share my screen with you and I'll show you guys what it looks like here. I just pulled it up on Google, but this is the book here. Okay. They have like older versions, so you could probably find the older version for like less money. It should all be the same. Honestly, the only thing that they're going to do is they're going to probably have changed their anatomic illustrations in the book, but we know med term and anatomy doesn't change. So that's always an option if you're looking for books. Like I said, I know you can get them on Amazon. I don't know how much they are on Amazon anymore. But you can even get like there's a second edition that's out there too. But I think this is probably the best one that's out there. I used to teach from this when I taught at a local college here in town, and they had a whole separate book. Um, we had a whole separate class for medical terminology and then anatomy. And this is a really, really good book. I know it is, I mean, it is going to be an additional investment, but you're going to be able to pull this book with you for years. I think I even still have one of them around here from whenever I was teaching years and years and years ago. But this one is a really good book. Um, this one, like I said, it's got both med term and anatomy. It's got a bunch of questions and things like that. And if you guys do get it, I can pull the answer keys so that you can have like the answer keys for your practice questions and exercises and things that are in the book. Okay. Any other questions that you guys can think of?
I had one question
Yeah.
on, I don't know if it's question 405. Excuse me, 405. They had the K
Mhm.
wires.
Yes.
How come we do not code for those?
The K wires are the percutaneous treatment. So anytime you see K wires, then that should be your clue that it's a percutaneous treatment. So it's going to be included in the code for the percutaneous treatment.
Okay,
Yeah, good question.
perfect. Thank you.
Absolutely. Any other questions that you guys can think of? All right.
No, I just have a comment. Sorry, I don't want to
Yeah.
take up too much time.
No,
But
you're fine.
for example, I was working the cardiovascular system a couple of days ago, and I couldn't find I didn't really know much about the aorta or any of that stuff, and I was working on a test question that said if the catheter the catheter stayed within the aorta, so it was like working in the descending thoracic aorta and then the root and all that stuff. And in the beginning of the cardiovascular system, it has a depiction of the aorta because I know in the question it'll say, "Oh, the catheter was here and then here and then
Yeah.
here." And then basically, if the catheter stays within the aorta, it's non-selective.
Yes. Yes. So selective catheters mean that, hang on, I have it written down here because it's one of those that I always have to um selective means that it advances from the original vessel. So the initial insertion point is going to be your original vessel. So if it advances from that initial insertion point, that's going to be selective. But in your case, like you said, because you punctured the aorta and it stayed in the aorta and it never left, that's going to be your non-selective.
And if they repuncture the aorta, it's still non-selective, like in a
Correct. Yep.
separate procedure.
Yep.
Perfect.
Yep.
Thanks.
You're welcome. Absolutely. I know cardio is a whole mess.
Oh yeah, it took me 10 hours to just do cardio. There's
Oh
so many
yeah, I can
guidelines.
imagine. Yeah. Yeah. I'm studying for my cardio certification now and it is, I mean, it's tough. It's a beast. So I get it.
So a question I have is because I haven't for all along when I've been studying the CPT guidelines, I've only been reading the beginning guidelines that are the shorter ones. And like I don't know how I could read all the guidelines for each section within a week.
Well, you don't have to do everything in 1 week, especially with cardio. Like your smaller sections, respiratory, you probably could get through those in a week if you were dedicated, but cardio, that's going to be one that, I mean, I know multiple students that have broken cardio down when they do either self-study or self-paced. Cardio can sometimes take 2 to 3 weeks to get through everything.
Yeah.
So
I mean,
it's not,
I don't know if it's wise for me, but I think maybe even though I studied a little bit on Monday and yesterday, I think it's just, I think maybe this week I might need to take off from doing anything studying related.
Yeah, I mean, if you've got a
I
lot of
don't know if,
personal stuff going on and just
well,
if
maybe
you're
not
not
a
able to
lot of
mentally
personal stuff.
focus, then yeah, I mean, definitely take some time.
Yeah, it just, like, yeah, I think it's just, I mean, the issue was, like what I'll just give you a hint about what it was there was something on that I had thought was resolved,
Hmm.
and then like when I got the text, early Tuesday morning, it was a desire that a hope that was deferred. And for
Yeah,
someone like me with autism, when something I've really been excited to is deferred, it takes a real
yeah.
toll
No,
on
it
me
does.
mentally.
Yeah, yeah. Yeah, if you're not able to focus, then to absolutely take time and take a week off or take however long it takes you to kind of recoup from that
I
setback.
mean, I think it's just my reasoning is, I won't be able to relax until there's a rescheduled date. But I know
Hmm.
that, but I know that probably might not be, and it's just really hard, not knowing when the rescheduled date could be because
Right.
it was a hangout with a friend that I was really looking forward to seeing, and now it really took a toll on me.
Sure. Sure. Yeah.
I know that God is sovereign. It's just like yesterday was a really, really tough day for me. Like it was
Yeah.
just hard at work, like my mind was racing a lot while I worked. I didn't due to the fact that my sleep got interrupted, like due to the fact that I had trouble falling back asleep, even though I did. Just with that and like everything that was just upsetting me, it just was hard to get through the workday yesterday.
Yeah. Yeah. I mean, just take time. That's all you can do. I mean, your brain and your body will know whenever you're ready to jump back into it.
Well, Tiffany, thank you. I
Yeah,
appreciate it. I mean, some
absolutely.
people think I should pursue my certification because they think me having my certification and never using it is better than not having it.
Yeah, and it all
I mean,
just
what do
depends
you
on, yeah, I mean, everybody's going to be different. It's not going to be
like?
anything
I
that
don't know if
opens
my
up the answer,
reasoning,
but for
for
you,
not wanting to pursue it, if my reasoning for not to pursue it is just because I'm simply tired of having to just study and just feeling like I'm not getting anywhere.
yeah, yeah. Well, I
Well,
mean,
thank you, Tiff.
just kind of take some time and think about it and decide what it is that's going to be best for you.
Thank you again. Yeah, and
Yeah,
it's just and also with
absolutely.
Practicode, like how hard is Practicode?
It's definitely not easy. I will put it that way. There's a lot of nuances in there with it, that you'll kind of learn once you get in there. But I mean, it's definitely something that's going to take a pretty decent amount of time.
And the question I have is, like, if I mean, I like the section that I'm still on in the study guide is like the practice, the chapter 20 exam A, and
Mhm.
it looks like I've gotten a lot of them wrong. I mean, I'm still not done with that exam yet, and I mean, like, and you said, if I keep failing the practice exams, then maybe let you know.
Yeah, we can schedule some one-on-one coaching time and kind of
Like, how
work
much would that
together.
be?
My hourly rate for coaching is 75 an hour.
Okay, thanks for letting me know.
Yeah, absolutely. All right, guys.
Good
Well,
night.
I'm gonna hop off of here. You all have a good night, and I will chat with you all next week.